us on the webinar today. This is Stephen Butters, Product Manager at Visual Sonics. I just wanted to thank everybody for joining us on the webinar today for shaping high-resolution imaging in preclinical research. So today's webinar is going to mainly focus on how imaging and imaging science can guide a drug development pipeline with a special leaning towards cancer drugs, cancer drug development. So just a couple of notes about the webinar before we really get going. We are recording the webinar right now, and this recording will be made available afterwards. There'll be a link sent to you in the email after we're wrapped up. All of the phone lines, the voice lines, are muted for the duration of the webinar. So if you do have any questions as we're going, please use the chat window on your webinar portal. Send the question in, and we'll make note of it and try to answer some of those questions at the end as time permits. The expected duration for the webinar is about 45 minutes, plus a bit of time at the end for some questions and some wrap-ups. And please always do keep an eye on our website, on the webinar section of our website. There's a link there at the bottom of the screen. We try to do a webinar fairly regularly, about once a month, so please register and join us. So today's webinar is going to be presented by Dr. Mianlini Lakshman. She's the Visual Sonics Applications Marketing Manager. And she comes to us, has been with Visual Sonics for a number of years now with lots of experience here with various types of imaging, ultrasound, photoacoustics, and contrast imaging. She joined us with a fair bit of background in basic research in cancer, doing a doctorate in research at University of Toronto with fellowships in Northwestern and also at U of T as well. Been well decorated and well awarded throughout her career. So Mina is going to give us a good overview of what is available right now for image-guided development and cancer drug development. So I'll pass it over to Mina now.
Hi, thank you. Thank you all for joining. I have an exciting queue of slides bringing together a summary and an overview of what's available in terms of image-guided cancer, for imaging-guided cancer drug development. So we'll move on to the next slide. Slide view and agenda. We'll start off with preclinical evaluation of lead candidates. I'll provide you some examples of stories from your colleagues. We will take a stride in tackling translational challenges, particularly with respect to high clinical attrition rates on drugs, and perhaps does it have to do anything with models that we are using in preclinical evaluation. And finally, we'll address a few next generation imaging for cancer therapy, and we'll close off with questions as Steve had mentioned. So I'd like to open today's lecture with a schematic on drug development workflow as shown in this slide here. It came from a recent publication in Nature Reviews. And from this workflow, if I was to say where we are going to focus our lecture today, it will be in this area: candidate drug identification, preclinical drug development, and hopefully increase the candidacy of these drugs so that they can be successful for clinical utility. This has been a stride in many cancer research programs and cancer institutions. So I'm going to take the approach today to leverage the mechanism of drug action to demonstrate the benefits of micro-ultrasound imaging. As you can see here, this is an image, a micro-ultrasound image of the abdomen, and I'm going to show you where the tumor is. And understanding the images and leveraging that information to address the preclinical evaluation of your lead drugs will be the common thread throughout the lecture. So just is to make sure that everyone's on the same playing field and understanding of micro-ultrasound. What we're talking here today is micro-ultrasound, which is high-frequency ultrasound. Just for comparison, the top row shows you the frequency of the ultrasound used in the clinic, 3 to 15 megahertz. That provides a resolution of 2 to 300 microns, as seen here. This is an ultrasound image of a human fetus. High-frequency micro-ultrasound is in the 30 to 80 megahertz, great for small animal imaging where preclinical evaluation takes place, whether it be mouse, rat, and to some extent rabbit and pig skin imaging. It's in the orders of 30 micron resolution, as seen in the micro-ultrasound image of a mouse fetus. So just the workflow, basically you have the small animal subjected to a high-frequency ultrasound that provides an image shown out here. Sound is reflected with minimal absorption and scattering, and basically the image here is it captures variation in tissue density created by reflective boundaries. Benefits of micro-ultrasound are very obvious. It's high resolution maintained at depth. It's real-time, non-invasive, and non-radioactive in vivo imaging. So let's jump into lead candidate preclinical evaluation. So for this, efforts in drug development is to evaluate the primary endpoint and generally that primary endpoint is anti-tumor activity as shown out here. For example, if the mechanism of drug action is to eliminate viable cells, basically if it's an anti-proliferative activity, then the primary endpoint of anti-tumor activity is defined by change in tumor dimensions. So for an ultrasound image of a tumor out here, you can capture wire cage images as shown here of that tumor in 3 dimensions right from the micro-ultrasound scan. Now, here you're seeing the volume of a tumor when subjected to a lead candidate as compared to saline. You have volumes provided in numbers out here supporting an anti-tumor activity. Now, there is one thing to remember, and this is where the complexity of the disease arises, is that while there is a reduction in tumor volume, there is no regression of the volume. So for this, there are investigations to see if the tumor microenvironment, particularly the contribution of tumor vasculature, if it has a role, and if that can be imaged simultaneously. And this is what I'm offering out here in this slide. So there is an anti-tumor activity seen by this lead drug. There is not complete regression. An investigation for tumor vasculature can be used by imaging in 3D Doppler. Now, what that means is while you're imaging the vascular network, capture it in a live mouse, imaging the movement of red blood cells through the vessel with dimensions down to 100 microns. That is the image you see right out here. So I'm going to a recent report by Huang et al. That actually uses to see what happens pre and post treatment. And right as you see here under the pre-treatment column, you see Doppler images, that is the image of the blood vessels down to dimensions down to 100 microns. You can see pre-treatment how 2 different tumors look, and post-treatment how that network changes. 2 things to keep in mind. It's not only the network, the tree of blood vessels in the tumor that change, but also look at the change in the intensity of the color, the orange color. These 2 pieces of information was then supported the conclusion that marked reduction in microvessels was observed. May I take a moment here to inform you that you need to mute your line so that we can continue with the recording. Thank you very much. All right. So right now we've used ultrasound imaging to look at anti-tumor activity by measuring the tumor burden. There was no contrast injections involved. It's just basically swapping the ultrasound transducer on the tumor site to measure tumor volumes. But then we went on to look at a spectrum of blood vasculature. But to address changes in microvasculature, we need imaging to address the broad spectrum of vascular dimensions. And for this, I'd like to introduce the tumor microvascular imaging with the help of contrast-enhanced ultrasound. Here is such an image of an orthotopic pancreas tumor. And I'm going to use this particular imaging approach to address two different types of lead candidates. One, addressing first-generation therapeutics or angiogenesis inhibitors. And the second class of therapeutics which are emerging in the field, which selectively target tumor vasculature using vascular disrupting agents. May I please remind that everybody mute your lines as I cannot progress through the webinar. Thank you. All right. So just before we go, we address these two classes of therapeutics, here is a list of cancer drugs that were that performed imaging-guided preclinical evaluation. These drugs range from products from Regeneron, from Pfizer, from Eli Lilly, few. If you can see through this tabulation, the imaging parameters that all of these companies used, or these products used, was the functional assay using Wash-in of Microbubbles. So I'm going to leverage the story from Regeneron that was actually broadcast last month, provide some conclusions on that in the next slide. Just before we go there, I want to make sure that everybody's on the same playing field.
Yes.
Thank you. On the same playing field on the methodology of contrast-enhanced micro-ultrasound. Here I'm providing one slide to show you that the contrast-enhanced micro-ultrasound uses microbubbles, and their dimensions are 2 to 3 microns. They have a gaseous core with a phospholipid bilayer and resonate to the frequency of the ultrasound transducer. Generally, it's administered tail vein, and once the transducer is placed over the site of the tumor, images can be generated. What in consensus is the following imaging parameters. You can see here on my screen on the slide that the imaging parameters range from frequency to concentration, and this consensus in imaging parameters was particularly acquired using large tumors in subcutaneous models. So keep this when you're going into orthotopic models. So we went over the scanning parameters and acquisition of an image. I just want to go over how you would analyze and report the results. The most important thing is the time intensity curve, as shown out here. Basically, it's a graph plotting the contrast intensity over time. And as the bubbles get into the field of imaging, you will see a fold of increase in the signal and then a plateau. So these are your two key parameters to look at when you are analyzing and reporting. There are two indices of reporting. One is blood flow rate that looks at the slope of the curve, or also called washing rate. And the second one, which is the difference between the baseline intensity and the plateau intensity, which looks at which can be reported as blood flow volume, and the particular index for that is peak enhancement. So let's see how two different studies used these indices and how the plot changes as a function of treatment. So here's a study that was discussed last month, and I'm going to be brief on the conclusions of the study. Basically, it's a study addressing blocking of VEGF with the Regeneron product. It's currently in clinical use, and this study reported the contrast intensity based on peak enhancement across colorectal cancer cell lines in a subcutaneous model. The author in this study made the conclusion that the change in blood volume, to support that the change in blood volume as measured by contrast-enhanced ultrasound is an early response biomarker to assess treatment efficacy. This inhibitor is now in clinical use. Moving to a second study, this is Eli Lilly's gemcitabine. Here, this was a report by Dr. Robert Kerbel, a father figure in the field of angiogenesis in experimental therapeutics. His group reported likewise there is a change in perfusion with treatment as compared to before treatment. But here you have to keep in mind the mechanism of drug action. This is a drug that's a nucleoside analog, so it has a different form of action. But in this study, they made the conclusion that there is a relationship between drug delivery and its anti-tumor activity. More specifically, you can see that with the drug, there is an increase in perfusion kinetics as defined by the wash-in rate. You can see the blue bar graphs are increased with treatment and also peak enhancement, the blood flow volume, also increased over time with treatment. This increase in perfusion kinetics as defined by these two parameters also coincided with tumor volume as increased treatment efficacy over time or decreased anti-tumor activity over time. Okay, so I want to provide you with this slide because it gives you an imaging-guided way of looking at the guts of the tumor. You can see that in the top row where there is pre-treatment across 4 tumors, they all have basically the kinetics as defined by peak enhancement appears to be relatively different. However, after treatment with sunitinib, an angiogenesis inhibitor by Pfizer, you can see that across all 4 mice that the inhibition is decreased. Sorry, the perfusion is decreased. That story actually drives the high reproducibility using these drugs. Now we're going to switch to a different drug mechanism where these are vascular disruption agents. These particular agents are selectively or are reported to selectively address the tumor vasculature. So I'm going to take the story from Synta Pharmaceuticals that claim to disrupt and have shown to disrupt vascular network in both the center and the periphery of the tumor, therefore reducing the viable rim of the tumor. And for this, they use the Wash-in microbubble functional assay. So this is a schematic showing how they have improvised on other drugs as compared to their drug and inducing tumor death using that particular mechanism of drug action. They used, here's an image of a tumor that was used in their study, where they indicate the tumor margins clearly with ultrasound, indicate the tumor blood flow at least in this imaging plane as compared to the non-tumor blood flow. Here is that same time intensity graph. You can see that for this tumor there is a slope and then there's a plateau, and both the slope and the plateau is resolved once the tumor is subjected to the lead candidate. So their strategy was a single-agent efficacy for tumor regression and or anti-tumor activity, and they also reported no dose-limiting cardiotoxicity. I imagine that these two are very important parameters, a balance between efficacy and toxicity. Okay, another example of a single-agent efficacy single-agent efficacy story is the use of oxy-4503, which is a crumbrastatin. It's also a vascular disrupting agent. Here I would like to show you that while the drug has shown clear pruning of microvessels as shown here, I want you also to appreciate that when there is a change in perfusion, there is also a change at the molecular level, and in this case, I would direct your attention to look at the image right on the top, where there's a change in color from red in the periphery to blue. What this color change actually represents is the change in oxygen status. This change in oxygen status can be non-invasively and simultaneously reported using photoacoustics. Now, a more elaborate overview of this technology will be offered in the September webinar on ischemia and oxygenation, and I strongly encourage those who are interested in this simultaneous kind of imaging to attend that seminar. But in the meantime, the oxy-4503 was also found to reduce tumor perfusion, but this tumor perfusion was only well achieved at 4 hours post-treatment without the formation of necrosis. Now, this is important with vascular drug agents, as is still an issue as compared to the previous story by Cinta Pharmaceuticals, where toxicity was actually addressed. Okay. All right, so a quick summary on the part on lead candidate and preclinical evaluation for those of you in evaluating a lead candidate. We showed that there were anti-tumor activity by rapid micro-ultrasound and Doppler imaging. So the concept of scan, analyze, and report right on the system and in real time. Also, we showed that contrast-enhanced ultrasound used by your colleagues is an established turnkey and solution and offers a functional assay with high fidelity. Also allows you to do scan, analyze, and report on the system. We also discussed simultaneous imaging for efficacy and toxicity in soft tissues. Now, before I close this first part of the talk, I'd like to also share some additional tips that have been reported in literature. This is a sunitinib study where the authors wanted to find out if in large tumors, does the contrast intensity change depending on the imaging planes that they image? So here on the top graph, here's a pancreas tumor. The blue and red shows one type of it was performed in one type of pancreas tumor. The blue was the time intensity curve achieved in imaging plane number 1, and the red is the time intensity curve achieved in the imaging plane number 2. And you can see that since they sit on top of each other, it can be concluded that the microbubble perfusion does not depend on the imaging planes, at least in these tumor types. But if you take 2 different pancreas tumors, as shown, the comparison between blue and red in pancreas tumor type 1 and another subtype 2, you can see that there is a difference in perfusion kinetics. This was very well recorded in Olsen et al. Using a sunitinib study in pancreas cancer models. It was also very well recorded in a prostate cancer model from a European group, where different microenvironments exist in different prostate cancer xenografts. So I thought this is very important to share with you, especially when you are starting up your imaging methodology, that these parameters have already been addressed. Another additional tip is, it comes from Sutendra et al. In 2013, where they provide lines of evidences using different imaging. The top one is PET, the second one is contrast-enhanced perfusion using micro-ultrasound, and the last one is histology. And as you can tell that when compared to the control, the lead candidate here, or the drug here, shows a decrease in anti-tumor activity, decreased perfusion, also shown in histology. However, I'd like to point out right here that micro-ultrasound of tumors, as shown out here, is a non-radioactive approach. Is similar with PET, and in that way differs from PET-CT. Is non-invasive, and it differs in that way with histology. Provides a longitudinal assessment of the same animal, allowing the animal itself to be its own control. Of course, rapid scans and reports provide a time-sensitive way of addressing your investigation, and it's user-friendly. All right, we'll move on to tackling translational challenges, an area where I spend most of my academic career. And for this, I start with the very obvious question. What is the right tumor model to address preclinical evaluation? At least what we can discuss today is the trend. The trend for choosing a right tumor model has moved from subcutaneous to orthotopic and more recently towards patient-derived xenografts. And for that, I'm showing you images, gross images of a subcutaneous model here and an image. Obviously, this is an orthotopic model. See, you can't see major bumps in the abdominal cavity, but here are the relevant ultrasound images, the subcutaneous model right out here, and the orthotopic or patient-derived orthotopic model shown right here. Okay. In these models, one of the important things is that every tumor is different, and it becomes more real when you move into models that are patient-derived xenografts. And here's a study that we worked with members from the hypoxia group here at Princess Margaret Hospital in Toronto, where we looked at two different tumors. These are very large tumors, as you can see there, about 250 cubic millimeters, and we looked at their tumor microvasculature. We also performed, this is looking at the tumor microvasculature using contrast-enhanced ultrasound, and also mapping the guts of the tumor using our VEVO software, which I didn't go into too much depth. And you can tell that two different patients' xenografts are entirely different in their gut. One seems to be well perfused in the periphery, not so much in the core, whereas this is very heterogeneous. And maybe
I think the culture was getting a little warmer. Warmer? Okay. Okay. Just letting you know. Yeah. Okay.
Out that tumor number 2, in its earliest form, that is when it's only 18.2 millimeter cube, that means before it is even pre-palpable, can be visualized and scanned and further analyzed and reported, and has, you see that if you compare the two, even early on, it has a similar perfusion pattern. I'd like to take this time also to show you that ultrasound imaging has provided a new bladder cancer model, was reported recently, and this was possible because of ultrasound-guided imaging. One has to remember that establishing such models, particularly bladder cancer model, requires, in an orthotopic fashion, requires the injection of tumor cells in the wall layer. As you can see out here, is about 2 to 5 millimeters. I want to draw your attention to the group of images right here that shows successful implantation and growth of these tumors. This is the first study that actually can assess how one can treat bladder cancer using chemotherapy, single-agent chemotherapy, as shown in the graphs right here. I think we take great pride to see that ultrasound not only guided the implantation, but allowed the subsequent lines of evidence to demonstrate that bladder cancer can be treated and that can be treated by chemotherapy. Similarly, immunotherapy. In the field of immunotherapy, we've seen a recent report again in Cancer Immunology and Immunotherapeutics by an Italian group, where they also use ultrasound-guided intratumor injection of their cocktail of immunological agents, and this is in an orthotopic prostate cancer model, and the images shown out here is 3D ultrasound wire cages showing the volume of the tumor. What I would like to point to you here is that these two columns show the therapy, and these are mock studies. And you can see that with the mock studies, how the tumor volume over time increases, and the anti-tumor activity, however, is resolved with their immunological cocktail. I think the author was in making the statement that the accessibility to treat tumors, particularly in visceral organs, could have not been possible if not for echo-guided local immunotherapy. Now, cancer is so complex, and it also is a menace to radiation treatment. I thought this is an important story to our attention with respect to preclinical evaluation of lead drugs and the kinds of new approaches taken to provide treatment for cancer. And here I would like to focus your attention to childhood cancers, where evaluating approaches to exert synergistic effects is important, especially with radiation therapy. And here the author takes the time to changes in, decrease in pressure, the tumor interstitial fluid pressure, and you can see they use interferon B. They also show that with the interferon B, shown by the gray bars, and increase in perfusion also increases the oxygenation of these tumors. And this is a very
okay. Yeah. Another thing that she mentioned that
alveolar myosarcoma. This is a childhood cancer, and in current therapy, there is with radiation complications include impaired mobility and peripheral nerve injury. This is pretty traumatic for little children. And what's important is that the IFN mechanism, and increased tumor vessel normalization. As a result of that mechanism, you see increased perfusion as shown by this contrast image and increased oxygenation. All right. I'm going to show you this particular publication since we made the link in the previous slide that there is actually a link between perfusion and oxygenation. And here is a report from the Karolinska Institute in Europe that there is a relationship that can be addressed non-invasively between perfusion and tumor status. So here is an orthotopic pancreas model. Here's an image showing a heat map of high perfusion in this region and high to medium perfusion in the green region. And this is obviously scanned, analyzed, and reported by using this map. Now, this same imaging plane, by switch off a button for Photoacoustics, looks at the level of oxygenation. And as you can see, that the oxygenation is low in the green region, where there is reduced perfusion, and high in the perfused region. And I'm making the report that is high and low based on the change in color. There is a black to blue color map here, whereas this blue to red and white, which denotes higher oxygenation status. So on the right side of this slide, a similar image in another in a pancreas model is made out here. And in this particular graph below, what we're looking at is oxygen saturation as measured by photoacoustics and oxygen saturation as measured by an invasive method. And you can see that there is a direct correlation between non-invasive measurement with photoacoustics and traditional invasive measurement traditional invasive measurement. And the conclusion was that alteration in blood vessel volume and density precedes alteration precedes alteration in oxygen status. So that connection connection between the last two slides is very important when it comes to photoacoustics and cancer therapy, particularly in radiation therapy. Radiation therapy is in that field of precision medicine and personalized care. And an important question in radiation therapy is, when does the tumor reoxygenate? Because that is the mechanism of radiation therapy, to exploit cells that are oxygenated to induce DNA damage. So here are images, photoacoustic images showing oxygen saturation high in red, blue, medium, and no color low. And you see, just before radiation, this is the map that you see, color map you see. After radiation, you see this color map in 15 minutes and 45 minutes. What I would like to direct your attention is to how the color map looks overall as compared to this green region. See that this green region starts to shift from high oxygenation to low oxygenation, and then starts to restore to high oxygenation 45 minutes after radiation. This would be the right time to go after the next radiation dose. This was also quantified as shown in the graphs right here. The top graph is oxygen saturation as seen using photoacoustics, and the bottom graph is oxygen saturation as measured by invasive oxalite probe. That's the mechanism, that is the strategy used today. So this kind of approach allows us to perhaps increase the efficacy of radiation treatment by itself or in neoadjuvant therapy. So what we have looked at so far is how to image the tumor microenvironment, whether it be angiogenesis, perfusion kinetics, or oxygen saturation as a function of treatment, whether it be single agent treatment like chemotherapy or single agent treatment like radiation, or the combination of two, including anti-tumor activity using other drug mechanisms, and the more recent therapies using immunotherapy. So let's move on to some next generation pharmacoimaging. Here I'd like to introduce, and I will not be talking further, but there is a new line of formulating drugs, including drugs called thermogenic drugs. Here in this image, I'm just showing a picture of the poster child doxorubicin actually being coated in a liposome, and this particular kind of drug is driven. This kind of strategy is driven by the need to provide therapy at the site of the drug as compared to the systemic toxicity that we see today with standard drugs in standard care. The bottom image is actually an embryo sitting within its placental. There's a placenta right up here. And what I'm trying to show here is actually a photoacoustic image showing the presence of nanoparticles that are crossing the placenta barrier and into the embryo. And how do I make that judgment? It's because you see the blue to red color showing the intensity of the nanoparticle present. There is some nanoparticle in the placenta, and it has crossed the barrier because I do see the signal or color intensity pass and go into different parts of the embryo, including the eye, some into the heart, kidney, and perhaps some in the liver. This kind of assay has been used to at least evaluate whether particles can cross the placenta barrier, and if so, how it can be used for therapy in that area. While this is not necessarily cancer, this is an area of research in the next generation imaging. So I want to bring to your attention nano drug delivery. The question of when a drug is going to be delivered to the site of where the tumor is. And here, this is a study that was done using cetuximab conjugated to PEG and gold nanorods. This is in the forefront of nanotechnology, and using the gold nanorods to visualize where the accumulation of the drug takes place. This is a study done at the Yonsei University with Professor Su. Just want to show you how you can then quantify this accumulation. So here is an example of gold nanorods in a memory, in an orthotopic memory tumor. And basically here, we're looking at the ultrasound image before we switch on, by the press of a button, switch on the image as the nanoparticle goes in. And you can see that over time, after 180 minutes, you see a change and an increase in pixel intensity, showing the distribution and the accumulation of the gold nanorods. This can be then plotted, as you can see out here, in a graph plotting photoacoustic intensity over time, showing the accumulation increase in the tumor as compared to the memory fat pad. Now, this kind of ability to visualize between the normal tissue structure as compared to the tumor tissue structure provides an opportunity, a window of opportunity to address drugs to address when drugs get into the tumor compared to the normal tissue, and allows you to provide an increased efficacy of such drugs. Along the same lines, I'm showing you here the pharmacokinetic imaging of fluorescent porphysomes. And here we're looking at comparison of two different resolutions between full body imaging and photoacoustic imaging, just to provide you some insight as to the different information that you can get from photoacoustic imaging. While the porphysome is delivered right out here, 20 minutes later you can see that you're looking at the accumulation of tumor on the hind limb, and at 24 hours you see it brighten up. Now, we took the same animal and looked at it under photoacoustics, and what you're seeing here is two different types of signal, green and red, just to illustrate to you that the red is the signal coming from blood, and the green is the signal coming from the porphysome. And for those of you who use histology in your analysis and in your experimental toolbox, it's nice to see that the signal out here kind of reflects what you see in histology, where you see the increased this is not expression, but increased presence of the porphysome towards the periphery, and over time it goes along the periphery around the tumor, and then towards 24 hours that it actually starts to invade into the core. It sort of is consistent with histological expression of molecular markers. Another area of research with respect to cancer therapy is understanding oncogenes and using gene silencing approaches. Yeah. Here I want to present to you that the use of tyrosinase reporter can be actually leveraged to not only study oncogenes and their effect on tumor progression, but using RNA-related therapies to silence certain genes and therefore reduce and therefore enhance the anti-tumor activity. The next slide shows you how to construct a photoacoustic reporter. This kind of photoacoustic reporter this construct has been reported in in a journal by our friend Dr. Zemp in Alberta, and he has also gone ahead and looked at LAGZ imaging as well. But here's a construct for you if you're interested, and if you're in the gene silencing area of therapy. Particularly, this is very important in ovarian cancer. It's not the formation of the tumor, but the actual ascites of this tumor that is a menace for this kind of cancer. So we've seen a lot of gene silencing therapies, and we like to recommend Photoacoustic Reporter related gene silencing to address therapeutic efficacy. An advantage for using this tyrosinase as a reporter gene imaging is that it's multimodal. Just like I showed you, suppose I'm showing you examples where you can use ultrasound or photoacoustics in your existing imaging repertoire. Here, a reporter gene, using tyrosinase as a reporter gene, it actually serves as a multimodal contrast agent, as you can tell from the middle set of images, and it's multimodal because it can be used in MRI and PET. All right. Since I just brought up the molecular imaging component of it, there are molecular markers or biomarkers that can influence a tumor response or can be used as an assay for tumor response. I have just listed them here. I strongly encourage registering for the molecular imaging seminar, as we will go into details of that, details in that particular seminar. But just for you to understand what's upcoming, what's happening with molecular markers, and these molecular markers have used micro-ultrasound or photoacoustics, depending on what contrast agents that they have used in these in either one of the imaging modalities. I'd like to bring to your attention that the microbubbles, again, targeted to BR55, which is the kinase domain, the human form of it, is now a clinically approved contrast agent, and it's been used. It was reported in a colon cancer study. Right. All right. This now brings to the important component, or the second half of the component, which is safety and toxicity, and how do you address that? For that, I'm just going to take you to the next slide, where cardiotoxicity is a big issue with cancer drugs. And using the same ultrasound machine, you can just position the transducer right over the heart, and here is some measurements that we have for you using in a Simultaneous study. So here's an ultrasound image of the heart, the left ventricle, and demarcated by this red area before and after a Simultaneous study. And these parameters, which actually assess the function of the cardiac output, is then provided out here. You can see that post-treatment, if there was a post-treatment of cardiac output. So this is very important that you can do it on the same ultrasound image, ultrasound system. You can address the anti-tumor activity and the cardiotoxicity of the drug in question. So we have already addressed the anti-tumor activity. I'll just move on in the interest of time. Also important to note that while there are major cardiotoxicity parameters, you can also go ahead and use certain software packages like VEVO Strain that assess, as shown in this image, assesses early changes in the wall of the heart, the way it moves, using before and after treatment, and use that to assess if there are potential cardiotoxicities. You don't have to wait till there is a huge collapse in the heart's function. We will discuss more about how to assess cardiac function and early markers of cardiac function in our webinars on cardiac health or heart health. Toxicity not only happens in the heart, there are other organs where toxicity is an issue, including end effects like ischemia, hypotension, and these can be addressed depending on what organ is of interest to your preclinical evaluation, whether it's the kidney, liver, gut, or the skin. In particular, in cancer drugs, the ulceration of the skin is another organ to evaluate toxicity in addition to gut. Of course, I cannot finish this lecture without talking about the fish, the zebrafish. As you can see here is the image of our transducer just pointing over the zebrafish. Those of you using zebrafish for to assess either markers, biomarkers of tumor response, or the anti-tumor activity of your drug, would like to assess toxicity. And there is a nice paper that I have provided out here. Mishra et al. Actually claims that toxicity can be addressed within 3 minutes of administering the drugs, and you can get the cardiac function. Okay, so we have talked about the VEVO technique in the context of efficacy and toxicity in cancer drug development, whether it be first generation, emerging technologies, or next generation technologies. I'd like to remind you that this was done all in vivo with the premise that it's non-radioactive, non-invasive, and for those of you in the drug development world, it's 3R compliant. This is very important when it comes to the use of animals in a humane manner. I'd like to remind you that this is, all it involves, the VEVO technique involves, is to scan, measure, and report. And you've seen your colleagues use and show lead candidates go through the drug development pipeline into the clinic, and we wish them all the best with their clinical trials. In the meantime, if there is a need to better understand how to implement these kinds of protocols, I'd encourage you to go to our website, www.visualsonics.com, and register for courses that are available in the summer here in North America or ongoing courses in Europe. I'd like to also thank our pharmacoimaging speakers that recently gave their talks, one from Pfizer, one from Regeneron at the World Pharma Congress. They talked about clinical and the efficacy of lead candidate drugs, and also the use of preclinical ultrasound imaging oncology models, especially in this day and age where there's clinical attrition rates of these drugs, and there's need for a right model in which to address the preclinical evaluation of lead candidates. In summary, what we've seen here today is a possibility to simultaneously image changes not only in the structure of the tumors, but functional assays and how that relates to molecular changes. We've shown you how rapid and simultaneous scans can be performed. We've also shared with you that there is the in vivo assays that are turnkey in respect to being established, validated, and quantitative. I've also shown you examples where how you could use ultrasound photoacoustics with existing imaging technologies or invasive methods, and how the data from ultrasound and photoacoustics can be integrated into your imaging toolbox. So let me show you the system that we've been talking for the last 45 minutes. This is our VEVO laser. This is the micro-ultrasound component of it, and the laser box right beside it allows you to look at pharmacoimaging, molecular imaging, use nanotechnology, combine nanotechnology along with it in the context that we've talked about in the latter part of this lecture. The benefits are listed to you. I'd like you to keep in mind that this is one of the imaging modalities that provides you the output of physiological parameters. This is very important for cancer biology to make sure that the imaging is conducted in a consistent fashion, and that changes in body temperature or heart rate does not affect either the drug delivery or the drug efficacy. So with that, I conclude our presentation. Perhaps it was a very intensive one, but I'd like to welcome at this point those of you interested in seeing how from cancer drug development, how we move to looking at markers at the structural level in therapies that intervene into the vasculature. At this point, I'd like to turn back to Stephen.
Great, thank you, Mina. That was an excellent talk. We covered a lot of ground, a lot of different areas. Obviously, there's lots of flexibility in the technology to really advance studies and development in all these areas. We are getting some questions coming in on the chat window, so please feel free to submit any questions that you might have following up on Mina's presentation. And we've got a few here already, so we'll just start with the first one that came in, which was regarding high-frequency ultrasound and human skin imaging, about whether or not there are any safety issues with human skin imaging and whether or not perfusion imaging in the skin for certain conditions could actually be done with high frequency.
Right. Thank you for that question. So, at least in Europe, we know that there are right now clinical trials addressing that, particularly in wound healing clinical trials. Yes, microbubbles have been used in the clinic, and again in Europe, also in the United States, particularly in myocardial perfusion. So the answer to it is yes, and more people are breaking new ground, so it is possible. Using our system in the current configuration, an IRB is all that's needed at this point, and we're certainly happy to follow with you on a case-by-case and demonstrate where this has actually helped other clinical research-related projects.
Yes, absolutely. I would just add to that one of the parts of the question was whether or not there were any safety issues with high-frequency ultrasound, and I would say that there are none that we know of, but high-frequency ultrasound is not yet approved for use on humans. Having said that, there are lots of people who are doing clinical applications under IRB approvals, and for anybody who's interested in doing that, we have the availability here to help anyone through an IRB approval process that wants to do any clinical scanning with our systems. Another question that came in was whether or not microbubbles could be used to look at ischemia in the heart and do any myocardial perfusion work.
Ischemia, yes. Ischemia in the heart, yes, there has been, I can't remember at the top of my head, but maybe Stephen, you can fill in if you've seen.
There are a few. Attila Kovacs at Washington
yes.
University in St. Louis has done some ischemia reperfusion injury work. I know also Jonathan Lindner and Liza Villanueva groups at Portland and University of Pittsburgh, respectively, have both done some work with ischemia and myocardial perfusion with microbubbles in the heart, both in rat models and mouse
models. Wonderful, yeah. So we can actually follow up with those papers. If you can just shoot us an email. I think I have my email address up on the screen. If you want to shoot an email, we can follow up with those 3 publications to you.
You mentioned, Mina, some developments of thermogenic drugs as a concept, and there was a question that came in there. It was just asking if you could elaborate further on this area of research and the implications in cancer therapy.
Right, that's a good question because this is very new, and what I meant by thermogenic drugs is basically the implications to it is to increase the opportunity for drugs to be activated only at the tumor site and reduce the systemic toxicity. This I mentioned before. I didn't go into too much detail because this is work. This is work by Dr. Jonathan May at the Ontario Institute of Cancer Research. He's working on it. It's preliminary findings. He published it as a poster at the American Association of Cancer Research just last month, and received actually the VEVO Award for his work. It's preliminary, but the idea here is while the cancer drug in this case goes all over the place once administered systemically, it only gets activated with heat. And upon activation, and it's activated by heat at the site where the tumor is. So just by, I suppose if you were to speculate that in the clinic, you provide a heat blanket or a heat patch at the area where they have the cancer, the drug is activated, and you can image right away. In this case, in the preclinical model, image it at the site where the heat was, heat activated the drug, and C is anti-tumor activity. So they used photoacoustic imaging of tumor oxygenation as their readout, and they found that the combination of doxorubicin in a liposome, a thermosensitive liposome, when delivered to the site, and then at that site when heat was provided, the tumor oxygen status changed in favor of the drug.
All right, great. Just one final question before our time is almost up. There's a question about whether or not it's possible to explain the consistencies or lack thereof in tumor growth patterns between orthotopic and subcutaneous tumors, and also looking at the vascularity, changes in vascularity patterns and markers with targeted contrast in tumors as well.
Okay, I'll take the second part, the vascular, looking at molecular markers of molecular expression using targeted contrast enhanced ultrasound. Yeah, that can be done, and actually I quickly went over the table that I provided, and if I can perhaps go to the table that I provided in the webinar on molecular imaging and if they can be used as markers. Yes, the answer to it's still undergoing, but using targeted contrast enhanced ultrasound imaging, yes, you can look at those markers, so it will be non-invasive. I think we should be right here. So the VEGF-R2, P-selectin, endoglin was recently used for inflammation, but is also present in tumors. These all can be addressed using targeted contrast enhanced ultrasound. I'm happy to follow up with you. You have my email address again on the inconsistencies between the two types of tumor models.
Okay, great. So our time is up, I think, for today. For anybody, any other outstanding questions that we didn't get to, we will try to follow up individually with those of you. And just wrap up by saying thank you very much for joining us on the webinar today. Thank you again, Mina. Excellent presentation. Please keep an eye on our webinar section of our web page. We try to do these on a fairly regular basis, so jump on and join us and see what's new and what's developing in the field of imaging research in micro-ultrasound and photoacoustics. Thanks again, and that's it. Okay.